I think there are too many vaccines. We have known over the years that when science has advanced to a point that it is now important for many of us to know when not to use that advance. And I suppose in any field it's the same. Newer antibiotics come, it's an advance. We need to know where not to use them, rather than where to use them. Because where to use them, or you can use everywhere. But the question is, can you afford not to use them? Yes. And I suppose each scientific advance has this answer to be given. Otherwise, we will just mess it up with newer advances. And I think majority of the people in the community do not need these advances. So while advances are very important, but it's more important for us not to use. Like when there was no CT scan, it was easy. Now the CT scan, in Bombay, I always say that there are so many CT scan centers. I'm sure in Chennai the same. That if a child falls down, it is likely that he has fallen down near the CT scan center. So he first goes there, gets a normal CT of the brain, and after 12 hours when he seizures, he comes to you and me. And the parents say, but CT is normal, brain is alright. So, disadvantage of having so many CT scans. Earlier the fellow would go to a physician first, then find the CT scan center. So, I think there are too many vaccines. We need to therefore realize right from whether to use a vaccine, if so at what age, etc. Aggressive marketing. I think with competition comes an aggressive marketing, and each one will come and say how he is good. And I always feel that when somebody comes and says, oh, he is bad, I tell him that that doesn't mean that you are good. And why do you have to say he is bad? You have to say what you are. Aggressive marketing will come in. Dr. Panther said that safety and efficacy are absolutely nearly assured. Most of the vaccines would be safe and hopefully would be efficacious. The question is, would they be equally efficacious in our community? And I think that's an answer we need. Well, we will have an individual autonomy. I'm sure that each one of you in practice can decide yes or no for a given vaccine. But it's equally important what are the community benefits. For example, in your colony, yours is the only house which keeps it clean, and the others keep it dirty. Then even your clean house will keep on getting dirty. So the advantage of your cleaning the house will not really bear fruits unless you get everyone to clean their houses. I think community benefits therefore are very, very important. If few people in the community take a vaccine and the infective load continues to race through the community, even the vaccine may not have the desired benefit, because after all, vaccine is not 100% protection against any kind of virulent organism, any kind of epidemic. And I think therefore we will have to keep in mind what is the general community which is going to use the vaccine, and if small number use it, I think it will not have any great benefit even to an individual maybe who has had this kind of a vaccine. And finally, we have this voluntary situation, nothing is mandatory, so we have our own opinions. It's equally important that we have to strike a balance between science and activism. Activists keep on feeling that everybody in the medical profession makes money. I think there's nothing wrong in making money. If you and me as pediatricians make money in a child who comes to you with diarrhea, I think you have a right to make money, provided you told the parents how diarrhea can be prevented and the child should not get it again. I think then your making money is very, very valid. And I'm sure all of us do that. We don't promote diarrhea so that we get more practice. We prevent diarrhea. Okay, and I think that is how the activists feel that everybody who makes money is bad. The science says everything that is latest is good. I think we'll have to be somewhere in between. And to that extent, the next slide please, we will discuss first what has been my basis of deciding whether I should use a vaccine. And I need a basic epidemiological information. I need to know the prevalence of infection and disease. I'm sure every time we hear the same story, last 40 years in pediatrics, I've heard the same sentence at the end of the discussion to say, in India we don't have the right data and data needs to be generated. As if somebody else will generate and not you and me. So I think we may not have a data and that should not make us believe what the Westerners do. That may be even worse. And therefore, I feel that even in absence of data, while the data needs to be created, generated, I agree with that, and it's equally difficult. Academic keeps on trying to do that, and it does that by calling 20 experts and getting their feedback and their experience brought in as a reasonable evidence. It may not stand to scientific scrutiny, but the point is that I need to know prevalence of infection and disease. All 100 of you have that experience, what you are seeing. The worst part is we never document that, we never spread it across, we never share, therefore there is no data. But each one of you reasonably know. So to that extent, we need to have a reasonable look at what's the prevalence of infection and disease. Of course, age of affection, which is very, very important, and we mostly know reasonably at what age most of these illnesses are occurring in our community. It's very important to see the natural progress. For example, there are diseases which naturally progress very benign way and get better. Now, if you want to stop such an illness and prevent such an illness, it's not a great deal. It's anyway going to get better. We cannot give an example of an occasional situation where that benign disease also killed somebody. I think there are many more deaths on the roads of the city, traffic, and you still go on the road. And there are house collapses and still you stay in the house. So those are not the incidences that you quote and say, oh, I saw once a Varicella killing somebody. Yes, you saw once, but you saw many more times people dying on the road. So I think we will have to go by the natural progress, and I strongly feel that if a natural progress is reasonably tolerable, manageable, without trouble, then we are not at a point in the country where we want to even prevent such issues. The Westerners may do that. For example, in US, in an intensive care unit, they have only asthmas, child abuse, road accidents. That's not our problem. Okay, we'll still have diarrhea, sepsis, etc. So I think the Westerners may follow a different way, but for us, natural progress is very important. If nature cures you, then you are not required to neither cure nor prevent, is my feeling, because there are many other important issues lying, and it cannot be at the cost of that some benign illness is prevented, and I'm not one for it at all. I think equally important is the risk of mortality, morbidity, and sequelae. For example, an occasional infection or a disease may be less prevalent, but far more serious. You may lose life, or if you survive, you may be left behind with a serious sequelae for lifelong, like say a meningitis, for example, and you may be unlucky to be surviving with a delayed development. Now that's something that even if the prevalence is small, if possible, I want to prevent it. So again, it's not just the prevalence and incidence. Some disease may be 90% prevalent, but hardly any mortality, morbidity, sequelae, and another may be 10% prevalent, but with a serious sequelae mortality, and I would like to prevent that 10% prevalent disease, but I'm not worried about 90% prevalent disease, which is benign. And I think that's the way I look at it when I choose a vaccine. I think besides the epidemiology, it's equally important that the factors related to vaccine needs to be considered. For example, we are all aware that when a vaccine is used in a big way in the community, the infection and its prevalence, age prevalence goes on shifting. And there are enough reports to know that measles, for example, may have shifted a little, and you all may be seeing measles at a little older age. And therefore, we need to see what's the impact of such change in epidemiology by our intervention. Now, when it is measles, there would be many dying of measles in young age if you don't prevent them. So you're not worried what happens to measles in 5 and 10-year-olds or for that matter in adults. But a disease which would reasonably harmless, if you have a change in epidemiology, you might get into trouble. And for example, when we come to discussing about varicella or hepatitis A, those infections are even worse as the age advances. And in young adults or adolescents, those illnesses are more severe than even the young ones. If that is so, then I need to know what will happen if I artificially intervene at an age which I don't need to, and push up my epidemiology for them to suffer at the wrong time, because there are many questions remain unanswered, like when should you give a booster of such vaccines will not be known for some more time. And I think therefore that's very important to even consider. So I'm not worried about preventing something today. I want to know what may happen if I prevent something today. Will I face more trouble in my later life? And I think that's an equally important point for our discussion. And of course, lastly, the cost versus benefit. And you cannot say that, life cannot be equated in cost. In reality, cost matters. And today the vaccines will come more and more costly. And already a pneumococcal vaccine is in the market, which costs some 5,000 rupees a dose. You have 3 primary, 15,000. We will have to see what good it does by preventing pneumococcal disease. And I think we will have to apply that as well, and not just allow to say cost is not a concern. The next slide, please. Putting this into thing, I'm sure we know all that, and I have written the word optional because it was earlier, and I wanted to make a mention that this was not a good term. The option was not exercised by the parents nor by the child, of course, not by the patient, not by the doctors. Option was exercised by the industry, and they told us what we should be doing. Now, as he rightly said, additional vaccine is the right thing. Newer vaccine, what is new? It's old enough when it comes here, and therefore we know that some of them are really something that we need to discuss what it is. I will just run through some of the vaccines that have remained some questions unanswered, and I discuss with you what I feel. I'm sure Dr. Patha is with us to kind of give his very, very learned critic on what I say, and this is what I feel strongly, and therefore I like to put it across to you. I think hepatitis B is not a debate anymore. There were debates by one extreme group to say, our prevalence is so small, forget about it. There were adult gastroenterologists who barked at us and said, the hepatocellular carcinoma and a chronic disease and cirrhosis, that must be prevented. As pediatricians, we knew that the pool of hepatitis B in the community largely contributed from young ones. And almost more than 50% of the pool in the community of hepatitis B carrier is coming from a neonates who may get infected. Therefore, for us, it's very important to prevent the neonates from getting hepatitis B because they would not only suffer themselves, but they will contribute to the pool of the total community load and keep on therefore never getting this disease under control. The disease is terrible, the treatment hardly any, the complications too many, and the vaccine now reasonably available in terms of economics, plenty, and to that extent, I think there should be no reason. In fact, one of the reports in 2005 Lancet said very clearly that it's ethical to use hepatitis B vaccine even in low prevalent country. So I think that debate must die out. It was again the activists who came on saying that, who said 4 or 5%? It's not even 1%. I think that thing should die out. But the next slide will demonstrate what I feel again. I think we must stick to 016 schedule. I am aware that the schedule like 6, 10, 14 weeks may be acceptable, but to me as a pediatrician, I wanted my neonates not to get infected. Not knowing the maternal status often, and therefore it was best that I gave it at birth, and I strongly follow 016. I don't think 6, 10 and 14 weeks is a better schedule. Well, it could be an alternate schedule only if you have missed that opportunity. And I strongly feel that we must stay with 016, which is a better schedule for a better effective control of a neonatal probable maternally transmitted infection. Today we know that we don't need an immunoglobulin a great deal. Even without immunoglobulin, large number of them will be protected by a very early hepatitis B vaccine. And the immunoglobulin, which is very costly, will add only to a small benefit. And to that extent, if somebody can afford, and if the mother is E positive, that means there is a very high chance of a maternally transmitted infection, then you may consider even using the immunoglobulin, but I think that is very optional. Even if you use a vaccine, that's reasonably equally good. And I think I will stay with that. There were some other problems unnecessarily brought up as pre-S1 and pre-S2 component. We are aware of a mutant strain which is likely to be there, but all those are very minimal problems as of now, and we cannot overcome them right now. And I feel all brands are equally immunogenic and safe. There is no reason to believe that one brand is cheaper, therefore it's less efficacious. And I think you use the brand that is economically very good. And I think all brands are equal. I'm sure some of you as senior pediatricians have used hepatitis B Engerix at 350 rupees a vial, and now it is down to so much. You can see how the vaccine really costs a little, but to begin with for whatever research, development, etc. But it is good enough to say any vaccine is good, and I'm sure all immunologists and vaccinologists agree that even if you change the brand for whatever reason, it does not matter. That you don't know which brand he has taken first, it doesn't matter. All brands are good, immunologically safe, efficacious, and I think hepatitis B should not be our debate at all. Coming to Hep vaccine, I think we are moving in a discussion in a way that it is getting more difficult to institute it at all levels. Up to hepatitis B, we are okay, and I think we are with all. When we come to Hep, we need to give a clear thought what it is, and we know that the 30% of total meningitis and pneumonia in our country, with our own multicentric study some years ago, have shown that 30% are contributed by the Hep. It's an infection that you cannot avoid because it's an aerial droplet infection. It would come to anyone. There's a very high risk of mortality, morbidity, sequelae, and the invasive disease is very much common below 1 or 2 years of age. And therefore, the Western data had shown that pneumonias, meningitis in West were almost 70-80% due to Hep. That was a major infecting organism there. We may not know what has been our such contribution, but it's enough to know that it exists. 1/3 of those pneumonias, meningitis are caused by Hep, and there is a serious invasive disease in the young children. As against the pneumococcal, which I feel would be far more seen in a little older age group and much less invasive. And therefore, between Hep and pneumococcus, I certainly give a priority to Hep, also because I'm facing younger children, infants and toddlers, under 2 years of age, with serious complications. And I think to that, we know that this vaccine, if possible, should be included. This is the first vaccine I will include to somebody who cannot much afford. Okay, if he cannot afford, I'll forget it. But if he can afford a little, then I think this is my choice beyond hepatitis B, DPT, OPV, measles, MMR, etc., which I'm sure are here to stay. There is no doubt about that. But this is my first bet. We'll talk about the combination vaccine. Just now, Dr. Partha said that there are questions raised about combination, about the liquid and dry lyophilized powder presentations, etc. And we'll try to see how science looks at it. The next one, please. The issues with combination vaccines have been whether the immunogenicity of individual components has been well retained. There's always a fear that when you mix up so many, you may be losing on an immunogenicity of 1 or 2 of its components. And I think here there is reasonable now an acceptance all over that the combination vaccines have come to stay. And the science has gone past the problem that may have been raised earlier. And I've just quoted a few examples of how there are enough literature support. This study, which was done in 2002, said that it's equal if you give them all together or give them concomitantly but separately. And I think today's trend is to use more and more combination vaccine, and very soon we will see more than pentavalent, hexavalent, septavalent, etc. And that is, I think, going to be very, very much of an advance, because compliance will be taken care of by just one shot if possible. There are issues of this, and we know therefore that most of the combination vaccines are fine. Not all, but most of them. There was an issue about the liquid vaccine also, and it's reasonable. The latest report I found in Bosby's Drug Consult of 2006, that the pediatrics, which is used in the West, which has a DTaP, HPV and IPV combination, comes in a single liquid formulation as 1 dose. But HIV is given separately, in United States even today. And I think we will see why that is so as of now. So it looks like that the dry lyophilized form and the liquid form seems to be reasonably acceptable, and both are equal. You could just place your hands on one or another, and there is nothing better to choose one from another. For a person like me who doesn't have a large office practice, I think even if I spend diluting it on a dry powder, it means I spend little more time with my patient. It's worth my charging. If you are very busy, then you might say, I want a ready-made vaccine. I suppose both are equal, and therefore, you must have seen a dermatologist who diagnosed acne. One of my friends said, oh, he charged so much. He just diagnosed, but what he does there, he has a magnifying lens. He looks at it from all angles, because after all, he has to justify charging. So I suppose you can use the liquid vaccine versus dry lyophilized. To me, it does not matter, and it should be reasonably equal. But I think just coming in between for what is likely to happen in future, you are going to have a polyvalent vaccine. You are going to have a combination of even a DTaP with an Hib, which might be effective. And the best part that I read recently was there is a lot of research in trying to avoid even a cold chain. And I think if that comes through, that's a big breakthrough, because we are worried about cold chain. You are delivered a vaccine probably cold, but not necessarily cold chain. And therefore, there is always an issue with a lot of power problems. We ourselves don't know how to store those vaccines. And I'm sure all of us will have to have a backup, at least of a good container, which can be having a vaccine shifted for some hours if the power fails down. But if it happens in the middle of the night in your clinic, nobody knows it went through. So there are issues, and the science is probably looking at vaccines which can be stored even at room temperature, and I think that is pretty interesting. Coming back to the Hib combination vaccines, I think all brands are equally immunogenic and safe. Again, making a strong plea that if somebody comes and says, my vaccine is superior, he's talking nonsense. Every vaccine is equal in reasonably safety, efficacy, etc. The TPT-Hib combination has also been a question of debate, and today we know very well that the DTaP, when combined with Hib, is shown to have a lower anti-PRP antibody titer, and therefore, as of now, the earlier I showed of pediatrics given separately with Hib. The reason is that the West uses DTaP regularly, and combining DTaP with Hib has had some problem, though I read an article which says that it's getting overcome now. But as of now, we know that cellular pertussis seems to come in the way of an good HIV immunity, and an anti-PRP antibody titers are lower. But just get to the wholesale vaccine, and even it's higher and better. Therefore, the DTWP can be safely combined with HIV, and there will be no problem at all. But those countries or those patients who want to use DTaP probably, as of now, need to have an HIV given separately. And I think to that extent, we are very, very clear about the combination of the wholesale pertussis DTP combination with Hib is a fine combination, and it has no problem of immunogenicity at all. Therefore, most of the combinations that we use here are of DTWP. If that is what you are using, if you are using a DTaP, then it's better that you push Hib separately, and I think that is what I strongly would consider scientific. I would hesitate to combine the two separate vaccines in one syringe when the manufacturers have not given it so. And I feel it's illegal. Whether it is good, bad, safe, etc. is not my issue. If it is good and safe, then manufacturers should at least give two together in a pack, like some of the dry lyophilized form comes in, where you have a DTP as a solvent and Hib as the dry lyophilized powder. It is given as a pack. It is a clear indication that two can be combined. But you can't fool about saying that I'll take one from here, one from there, etc. Arguments are always there that no, not all companies manufacture all the components. So they buy from here, there, and also mix. But then they are mixing it. I think they are responsible. The technique involved is something different than you are mixing at your clinic with same syringe and two things from two different vials. And I feel there are people who come and say, oh, that is safe. I would hesitate to do that. I would request them to put them in one pack if not in one vial, for whatever technical reasons, and then only use it. I'm sure it will not stand to legality if there is by chance some adverse reaction, and the question will come in, who the hell asked you to combine that in one syringe? You can't go by saying it has been said many people do it. If a thief is caught, he can't say many thieves are going scot-free. That's not his problem. So I suppose those things we need to be really on guard. Coming to DTaP, I see reasonably a higher middle class or upper class patient, and I explain to them what this A stands for. I think earlier we thought that DTaP is without pain and without reaction. It is not so. It has far less prevalence of pain and reaction as against the DTWP. There is no doubt at all. But there would be patients with DTaP who will also get pain. If you give DTaP, you will have to give HIB on the other side. So there are 2 pricks already. There will be a small reaction to HIB as well. And therefore, I don't think we should be telling parents that, oh, DTaP is painless and reactionless. It is not. Certainly, it's far much reactogenic than the WP. There is no doubt at all. And when I tell all this to my patients' parents, I think majority still prefer a DTWP. DTaP is just a luxury. And I tell many of my parents, patients' parents, jokingly that the life is full of pain. What are you worried about that WP pain? And the pleasure is there in life because there is pain. You can compare it. Okay, what is painless life? There is no life at all. End of life is painless, I suppose, but not life. So what they talk about WP causing pain, you know the reaction, you can give paracetamol, there's no great issues, and the cost is so much different. You're spending about 1,000 or 1,200 rupees as against just a small minimum. And therefore, I think there is no great advantage immunogenically. That I think we need to put it across correctly, that it's a better vaccine, it's the same vaccine, but less reactogenic. Now we move on to, I think this probably has died out, probably Dr. Partha will tell us more about it, but in between there was a lot of debate on new MMR. I think that new has become old and very old. I don't see much about it being talked, and it was all because all the preparations have the same measles and rubella strain, but the mumps strain was different. In some you had a Leningrad Z or a Gerillin or a Urib, and they said that with the Gerillin, the least incidence of an aseptic meningitis. What was an aseptic meningitis due to a conventional MMR without the Gerillin? 0.8 per 100,000 dosage. It was less with Gerillin. How less? It was less enough, not to even count. And most of us as pediatricians have never seen much of a problem with conventional MMR, and I don't think this probably died out. I don't even see much about it being talked of, but when it came as a better MMR. Now we know that all MMRs are equal. There are issues that are not yet resolved, and I'm sure we'll like Dr. Partha to give his opinion on when should we be giving booster dose. The Western world is talking about 5-year booster, 15-year school exit booster. In India, I'm sure we will not be able to generate data, but we must generate the prevention at least. Okay, data is fine, but prevention. And I don't know whether that is seen by all of you. But when we were getting trained, rubella syndrome was not so rare. In between, it had disappeared. I am afraid that I am seeing occasionally again, hearing or knowing or seeing, and I feel that there is a reason to debate when we should give at least the rubella part, and I think we will certainly get to find out his opinion on this and some guidance of what. There may not be a scientific proof to it, but let us do good to the community, even if there is no strong data. And MMR is a reasonably economical vaccine, that there should not be a debate. If I overdo things, it's okay, but if I underdo, I think it's a crime. And I think we'll like to hear from him whether an IFE is going to also push for a statement to say, now give MMR at this age again. But I think time has come, and we will like to hear from him on that issue. About the typhoid vaccine, I have my great reservations. I know typhoid exists. I know MDR typhoid is a worry, but I feel that typhoid vaccine is one of the poorest vaccines. It is not as good immunogenic. It's about 60-70% beneficial. It has its own drawback that it has to be given every 3 years. That's the biggest thing. Whenever the parents come and ask me, what about typhoid vaccine? It's 2-year-old. Have you not given it? So I said, what about you? He said, well, do we have to take it? I said, of course. You have to take it till lifelong. And the life is getting longer. In 1947, when India got independent, the life expectancy of an Indian was 37 years. Okay, now it's 73 years. Okay, so whatever we said, lifelong immunity is no longer lifelong because life is longer. And I'm sure all vaccines will have to be given again and again sometime. I'm sure that we will be giving measles vaccine to a 50-year-old, maybe. Okay, the geriatrics will have to learn from us to say when to repeat. But time has come. I remember my own teacher getting mumps at about 60 years of his age. And he told me that real second childhood has started. And I jokingly said, but sir, you are not behaving like a child as yet. I think the issue of typhoid is every 3 years, poor vaccine. Okay, better is hygienic precautions. And if you take hygienic precautions, typhoid, cholera, diarrhea, dysentery, infective hepatitis, viral A, so many things will be prevented. And I am not very much for this vaccine. But suppose I have to give it. Okay, the parents say, I understand. They all give it at 2 years and 5 years. Most of the time they don't come at a time when they need it. Dr. Partha said very rightly that efficacy, safety, but need of the vaccine. And I feel that in my office practice, typhoid is seen largely in older children, in older school children, not very young. Sir, I saw once a 6-month-old with typhoid. Well, that is in the Guinness textbook. Okay, I don't see that. And therefore, I want to prevent the older children, if at all. My philosophy, therefore, is that give it at about 10, 12 years of age, give it at 15 years of age. Okay, by 18 years he is an adult. He can decide whether he wants to suffer or not suffer. Okay, and therefore that's also a time when all parents keep on bothering you to say, sir, 9th and 10th, very important, tuitions, this, that. Tell them if possible, don't make him a doctor. Okay, so what 10th and 12th and all that. But now it's too late for us to go by. And therefore, I think it's fine to give it at 12 years, 15 years. All those important competitive years are well looked after. Thereafter, he can look after himself. I don't think typhoid is a good vaccine to start from 2 years, etc. Again, a paratyphoid is not taken care of. The old TAP was as good. It was only TA. The B was not covered anyway. So today, if my patient is prevented from typhoid and gets paratyphoid, it's an excuse to call him paratyphoid. Okay. So I suppose that the vaccine is not an important vaccine. And finally, most of the typhoid patients in front of MDR are getting better. And I feel earlier years we did see occasionally at least typhoid with hemorrhage, typhoid with complications, perforation. I think lately with an MDR coming, I think it has been also resistant to complications. So that is good. I think the nature is kind. Bacteria resistant and complications also resistant. I'm sure all of them get well. None of them gets well quickly. And everyone gets well. Not a bad thing to happen as far as that. But typhoid is not my priority really. Hepatitis A. Again, various questions that remain unanswered, and whenever questions are unanswered, even then you are supposed to answer to the parents. You can't say this is unanswered. You say, better you answer, I'm paying you. So you have to answer something. And I'm sure most of us answer anything. Sometimes differently to different people, sometimes by mistake differently to same person. That is in and I know a family physician was very busy. And people are very fond of asking, sir, shall I eat rice or chapati? They say, no, eat only rice. Chapati is bad for your problem. So he said, all right. After 15 days when he came for follow-up, he again asked, sir, what shall I eat? He said, only chapati, no rice. He said, 15 days back you told me something different. But this man was very sharp. He said, no, you know how science is advancing. And I read every day, so now it's different. That I'm sure that we need an answer. Okay. As most of us say, when I don't understand what is wrong, sir, see what this patch is. No, don't worry. Don't worry means don't worry to ask me a question. I don't know what it is. Basically, don't worry. So, hepatitis A. I think in Mumbai about 10 years ago, this study came out to say that 85% in low socioeconomic and 60% in high socioeconomic group by 15 years were already immunized. Who immunized them? Nobody, nature. Majority did not suffer disease. They were infected. And today I think you have a choice where to get your hepatitis A. It could be in Taj Opera, Green Park, not Green Park. Okay, so wherever. But hepatitis A can be available anywhere. The point is that this is a very common. Now you can interpret the other way. You can say, oh, that means Indian children are getting infected early, so you should vaccinate them early. That may be one way to look. The other way to look at it is, oh, many got infected without trouble. So why interfere? You can choose your debate the way you want. But let me tell you what I feel. Many of them have a subclinical disease. Many of them have had no jaundice history, and even then they are immunized. If you do their IgG HIV, it's already positive. So they got infected without the disease. It has a reasonable long-term immunity. We know now that, as I said, that life is long, so immunity may not be lifelong. But it's still a fairly long immunity after a natural infection. And you rarely would see in a short time a hepatitis A recurring. In fact, you may not have seen a hepatitis A recurring. So it is reasonably long-term. The best part of it is the disease is very mild, under 10 or 12 years of age. And the disease gets more severe as the age advances. And adolescents and adults who suffer hepatitis A disease, not just infection, usually suffer far more and longer than the small children. And I think this is quite understandable immunologically. For example, as the immunologically you are getting more and more mature, you seem to also get into trouble. Now it's quite a paradox, and I'll explain to you this paradox, and some of you may have heard this before, that if you are caught in the middle of the road by three thugs and you are alone, is it good you are strong or is it good you are weak? The answer is it's good you are weak. You raise your hands, he takes your purse, pen, whatever, and then he knows you are so nervous. He said, don't get nervous, I won't kill you, but where do you want to go? Just drop me at that corner. He happily does that because he's not interested in taking your life. Okay, if you are strong, you are in trouble. You think you are strong, you start fighting. What do you lose? Your pen, purse, everything, you lose your bones, maybe you lose your life. So it is better if you are weak. Should we give the same simile to our patients and say a child should be weak so that he can raise his hand? No, that's not right. Then where did we go wrong in this simile? Our correct answer is, when you are caught in the middle of the road, you should be strong, but you should know when not to act strong. So now you are strong and you act weak, you act nervous, and you say, please drop me at that corner, and at that corner you have two friends waiting, you whistle them, they all pounce together and then beat all of them. So our immune system must know when to act. And today you know that in a Hib meningitis, typically the literature came up to say that before you give the first dose of antibiotic, you give one dose of steroids. What does it mean? You suppress your immunity and say, don't show off. There is still time. Let me first push my antibiotic, then you show off your immune system. If this does not happen, you may end up with a damage. And I think that's what happens as the age advances in some of these illnesses, including varicella, that the disease gets more severe as the age advances, and in young age, they're not very strongly immune, they don't know how to fight. And as they go past that adolescent and young adulthood, they get mature and they know when not to act. But these youngsters don't know that. Their blood is boiling, their immune system charged. Oh, let hepatitis A come in, I will charge. They fight. If the infection is virulent, they fight hard. The damage is done on the host. I think when two countries are at war, whoever loses or wins, the loser is always the country where the war is played, because the area is destroyed in that country. Even the winner has a loss. And I think here the fight between organism and the child is always on this soil, and therefore this is always a loser. Some scar, some damage. Therefore, if this disease gets coming up for the first time in a bigger child or an adolescent or an adult, I've seen children coming at 15 and 18 years of age with hepatitis A with 50-60 milligrams of bilirubin. And it takes 2-3 months for them to get better. They lose 5-10 kilos weight. They're severely anorexic, they're vomiting, they're itching with a cholestatic face, and they're impossible to control. I recall one child of 16-17-year-old who had 60 milligrams of bilirubin. His PT was a bit deranged. He was otherwise all right. I asked one of the senior hepatologists from the city to have a look at him, and he said, "Why do you want me to look at that child? It's HIV positive IgM." I said, "Yes." "No hepatitis B, C, etc." "No." "He will be all right." I said, "Sir, 60 milligram." He said, 60 milligram? Then it will take 60 days minimum. He told me 1 milligram takes 1 day to get better. Oh, he literally took 2.5 months to get better. Point is, he suffered morbidity. No mortality, morbidity. In fact, in about 3-4 years ago, I don't recall correctly, maybe 2002 somewhere, an IP gave an article from Anand Pandit's group in Pune to say that the commonest cause of liver cell failure in children is hepatitis A. Now, that was not the right interpretation. He had analyzed 25 children with hepatocellular failure, and half of them had had hepatitis A, but they had A with E, A with Wilson's, A with anti-TB drugs, something common, not A alone. But the end of the conclusion was, therefore, hepatitis A must be prevented by vaccine in our country. I think that's a wrong interpretation. And to me, therefore, this is no chronicity. Unlike B or C, there is hardly any sequelae, there is hardly any relapse. You suffer once and you get away forever. I don't think this is my priority. And if at all I want to give it, then I want to prevent it there, when it gets severe. I don't want to prevent it in a younger age, because then I depend on the natural boosters. And I don't know when the natural boosters will be coming effective, etc. And I don't know as of now when I should repeat a vaccine. Today, after 20 years of MMR, I know that it needs to be repeated. I remember once when MMR came in, we were told that now this is one for life. You give it at 15 months, you are okay for the next life. And it's not true. How mathematical calculations of a predicted immune persistence is not right many times. And to that extent, I think we will probably not prefer an early vaccination. I practice in my office to say, until 10-12 years, don't worry at all. Be hygienic as much as possible. As a routine, I do an IgG HAV, which costs 250 rupees in Mumbai. And 8 or 9 out of 10 children are already positive by then. Because today, every child eats outside. You have a function, you have something, okay, they are exposed. And younger they are exposed, better it is to some extent. Now the question is, should you have even any one suffer? That's a moot point. And today, as I said, we have many priorities, so this is not my priority at all. And the varicella is something similar, almost like hepatitis A. But to me, varicella, I strongly feel, will teach us a lesson of life. What happens with a natural infection is intervened with an artificial infection. When I give a measles vaccine to a 9-month-old and an MMR to 15-month-old, this mother brings the child at 18 months and says, "Sir, my child has measles." I said, "No, this is not measles. This is some other virus." Okay, she doesn't believe me and she feels I'm defending my vaccines. Because it's difficult to call measles clinically. And it's not so with varicella. Varicella is a clinical diagnosis. You see a polymorphic rash, it is varicella. No other disease, infectious disease, is so clearly, clinically diagnosable. Therefore, we will know what happens to varicella with or without immunization. We will not know these answers to other diseases because the clinical diagnosis is difficult, virological diagnosis or bacteriological diagnosis is impossible. Therefore, varicella will teach us a lot. I feel varicella and hepatitis A share many things. They are mild, they are benign. Complications are hardly any. Sequelae are hardly any. Relapses are rare after a natural infection. Therefore, both share the same. And I feel both should have the same kind of approach, that you delay the vaccination to an age where it's likely to be more troublesome, is my strong feeling. But as I said, varicella is going to teach us a lot because it's a clinical diagnosis. And I tell you what I have been seeing in the last 3-4 years. One is that we were always taught that natural varicella will never recur. It's once a lifetime problem. And a grandmother knows it well. We have seen occasionally a relapse varicella after a natural infection, not artificial. We all know that natural infections are likely to keep the immunity much longer than artificial infection. And if a natural infection recurs, not commonly, rarely. It is an eye-opener that not all statements that we make are true. And we don't know whether the epidemiology will change. The virus will mutate. And we will have a problem of a recurrence, naturally acquired varicella. So that's one area to watch for. The second area, which is even more complex, is that we are told that varicella is a primary infection and a herpes zoster is an infection of a sensitized horse. I recall on few occasions, again rare, I'm not quoting it to be very common, but I remember on few occasions of varicella and herpes zoster at the same time in the same host. And I feel that's quite complex and perplexing, that you have a primary infection and you have a herpes zoster. And I recall a person, and I think it was Dr. Arur who got this together as well. Dr. Arur, a neurologist from Bangalore, had grown his beard, and I said, "What's wrong with you?" He said, "There's a story behind. He had a severe abdominal pain. For 2 days he was rolling in pain. Diagnosis was not coming through. And then on day 3, the herpes vesicles came up, and they knew that was a cause of pain. A day or two later, a varicella appeared. And his mother had said that he had a varicella even in his childhood." Now, the point that I'm making is that the epidemiology will always change depending on the situation of the host immunity and whatever is the pool in the community. But varicella will be one disease that will tell us clearly where we are going. If a natural infection may relapse, and if a natural infection has a herpes and a varicella together, I think it's already a warning that some things are changing, and the books will have to be rewritten to say that, oh, this does happen. Now add to that an artificial infection, I don't know what it will cause. I would rather prevent it when I'm worried about it. I won't prevent it when I'm not worried about it. And I'm sure all of you must have seen, if you have seen patients who have had varicella, immunization, it's not rare to see a breakthrough infection. In United States, it's known a breakthrough infection to occur in a daycare where the children go in a community. And what's a daycare in United States? 8 or 10 children together. And they say, oh, contact. Here, there are 100 people at any given point anywhere. I don't know what kind of contacts will be and what kind of breakthrough infections would be. And I can understand if there is an immunocompromised patient, he has a risk. But if he is immunocompromised, you don't want to give a vaccine at that time. And therefore, you will have to prevent it by acyclovir or whatever if there is a risk. And only such patients or a little older children. As of now, there is no reliable laboratory test to demonstrate that you have had an antibody already against varicella. Unlike an hepatitis A, where you can do an IgG HAV, a varicella test is not routinely available and reliable as of now. But tomorrow, if the test is available, I think I'll also follow the same hepatitis A rule that I would do it at 10, 12 years. Those who are negative, not sensitized, I'll give them a vaccine, not knowing when shall I repeat the vaccine. Those things will remain unanswered, but I'm sure some of the vaccines which are come up now here, the answers for repeat vaccine will come only after some years, and I think we'll have to bear with that. But to me again, this is the philosophy that I would go by. I'll end up by, in the next 5 minutes, talking about further recently licensed vaccine and what I feel about it. Influenza viral vaccine, I think it may suffice to say that this is not a vaccine we should start using. And there are a lot of limitations as far as the viral strains are concerned. Yesterday in Times of India in Bombay edition, I saw a report that the vaccine research laboratory in animal research at Bhopal has successfully come out with a vaccine against H5N1 bird flu vaccine. And it's already getting into phase 3 trials. There was a report. Now, all that will have to be we'll have to wait and see. Let's not start saying therefore that, oh, bird flu vaccine has come in, let's start doing that. They are injecting in birds just now, finding it reasonably good. Birds and human beings are different. Birds are innocent, honest. Humans are not. And therefore, we don't know how we will act. And okay, so, but yes, there is an advance and we'll take a note of it, but we'll not run through that. And to that extent, I think viral vaccine like this will have to be given every year. We'll have to have a new different strains of vaccine every year, and we cannot still cover our DPT OPVs. Whether we talk about viral vaccine, if you give it to an occasional patient under your care, even he's not going to be prevented. And what is flu? Luckily, flu for most of us and most of our patients is something that flies off by itself. And every time I see a patient of fever of 2 days, he says, "Sir, what is the problem?" I said, "No, it's ordinary flu." Now people are talking about the deaths with flu, and here, fortunately, the myth prevails that flu is something simple, and mostly it is. And what is flu clinically? Any viral infection. And what is viral that I don't understand as bacterial is called viral. And therefore, I think there are limitations. We don't talk about this vaccine a great deal. We have a pneumococcal vaccine. I heard in Delhi that this has become a hot cake. Prevnar is just launched already. And in Delhi, the socialites and elites are talking to each other whether they have given their child a 5,000 rupee vaccine. I'm sure with that kind of socio-economic growth, the company can be advised to charge 10,000 because there will be more elite talking about it. So I was amazed to say many people are using this vaccine regularly and they are very proud that they have used 5,000 rupees vaccine. I think if you had 5,000, you might give 5,000 children an OPV or a DPT, I suppose. And you would acquire a lot of goodwill than giving a pneumococcal vaccine to your child. 3 doses, 15,000 rupees, a booster, etc. I think pneumococcal vaccine, to my mind, has a very, very low priority. The invasive disease is not much common. The pneumococcal pneumonia is a common. Bigger children are often involved. Streptococcus pneumonia is largely drug sensitive. Yes, there are reports of drug resistance coming. That is because of our misuse. So let's guard against that rather than create a drug resistance and create a vaccine for that. I think to me this is not a priority at all. I'm sure I will not use this vaccine for some more time to come. But I've always found that I'm very much late in following anything good as well. But the advantage is majority of good things have turned out bad before I've started using. So I say good, I did not use. Occasionally I feel bad that I should have used it, it's very good, but I'm little delayed, doesn't matter. But many times I'm happy that I did not use it because some colleagues say, "Sir, I hope you have not used it because it's bad." I said, "Good that I didn't use it." Advantage of not knowing so much is to know a little late so that you are always right. If you are delayed, but you are right. If you are in a hurry, you may be wrong. So that's about pneumococcal vaccine. And the 2 new vaccines are about to come in. Rotaviral vaccine is going to come very soon. Again, I have my own reservation. I always look at what has happened when there was no vaccine. That now what will happen when there is a vaccine. Okay, newer antibiotics have come, newer problems have come up. Okay, we have not solved the problem. And therefore, I do not know. Yes, people will say, and in India, the best part to convince somebody is that 200 millions are suffering, but we are 1,000 millions, 1/5 only are suffering. 800 millions are not suffering. Okay, so I think those figures make us feel that something drastic has to be done. Rotaviral vaccine again will have the same limitation in my mind, but my biggest worry, and I want again Dr. Partha to comment on that, is what will happen to our OPV. Schedules are nearly similar. A 3-dose schedule, oral vaccine, and there are reports to show that if rotavirus and oral polio go together, then an oral polio immunity is gone. I think we are almost on the brink of getting rid of oral polio. Why are you after rotavirus? Let rotavirus be there and it helps to drive poliovirus also. Thereafter we will see what to do about it. But I think for me, that's not a priority. We are going to have a monovalent vaccine. The US uses a polyvalent vaccine. We are told that it is all right monovalent, 90% of the strains are same, 10% is all right. So I don't know the answer. To me, this is not going to be my priority and I will treat with ORS. And again on ORS, that if he allows me to make that statement, the zinc has come in. Okay, I have my own doubts. I know that the double-blind randomized evidence-based trials have shown zinc added to diarrheal treatment has 17% benefit. What is 17%? Rotaviral gets well in 3 days. I calculated 3 days, 17%, 12 hours. Who wants to get better 12 hours earlier? It doesn't matter. Okay, so I know that, I know zinc is good, etc. But my worry is that 12 hours benefit to some children will make all others suffer. How? Because every pediatrician is wanting to use a drug for diarrhea. And the IAP is trying to brainwash, saying ORS, 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 no drug. Now there is a drug. ORS will go back. Drug will come in. Damage will be more. And I think that is what the evidence-based situation is. And I was just talking outside that evidence-based does not mean that we implement it. In United States, they had traffic signals. Evidence-based showed that traffic police are not necessary. India, we go went by that evidence-based. We had traffic signals, traffic police, still chaos. Evidence-based has limitations because our evidence-based is double-blind, randomized control study. Here, everybody is awake, no bias. Totally uncontrolled, no control. And therefore, those studies have a limitation. And I feel rotaviral vaccine also will not be my priority. I'll again be a late user. By then, God knows what will happen. And the new vaccine is going to come, cervical cancer vaccine. I was amazed when somebody came and said, "Sir, what do you think about cervical cancer vaccine?" And I'm very happy because that's not my problem. The problem of middle-aged women, what am I to do with it? Oh, he said, "Sir, your pediatrician now up to 18 years. Oh, the vaccine should be given at 15 years. My God, I have a trouble. Cervical cancer vaccine to our adolescents, so that the papilloma virus does not cause cervical cancer." I said, what about dengue? So there is hardly any. The point is, this is going to be marketed next year. This is going to come end of this year. And very soon we will have 2 more vaccines at least by next year to talk about. And how nice if you can give a 15-year-old to prevent at 50 years of cervical cancer. I hope she survives till then and doesn't die of malnutrition or something because of giving a vaccine. The point is, therefore, that friends, I just gave you my version. But I'm sure that at least this must have given you a thought to say, should you use a vaccine? We're not talking about DPT, MMR, etc. I think there's no debate at all. Up to HBV, there is no debate. Thereafter, you will have to consider, and therefore the last slide, I would say that these are musts. This is if possible. This is my first bet if economically I have money to go by. These are usually ideal combinations. We are not worried a great deal about it. And I think the other vaccines, I plead that we must use it with informed discussion. Whenever a parent has come and said that, "Sir, my neighbor's child has had the Varicella vaccine at 2 years and Hepatitis A and Typhoid, but you have not given us." So what I do today is that I inform every one of them of every vaccine available. I tell them pros and cons. I tell them what my views are, and I leave it for them to decide whether they should use it. In India, the faith on doctors is so much, every time after all discussion, the parents say, no, but you only decide what you should do. Which is fine, you could say that therefore. But I think the informed discussion, whenever I ask the parent, oh, your neighbor has taken, please ask him why he gave it. He said, no, he said it's a good vaccine and you can afford it. Now your parent may be able to afford you to buy. Okay, you're not for sale. So where is the affordability as the primary thing? Affordability matters, but that's not primary. In fact, I always thought that rich people became rich because they spend less. Okay, so everywhere if it's 10 rupees, they'll say, can you have it for 5 rupees? So they become rich. Poor man gives 10 rupees because he said, how can I argue? So rich people are becoming rich because they spend less, and you think they are rich so they can spend more. Not a good philosophy. And I feel therefore I'll end up by saying that let us use these newer vaccines with some judgment based on our own experience as of now, till the IAP comes out with some clear thing. That's why they're calling it as additional vaccine, and they're making it clear that each one of us is responsible for that debate. And finally, in your own practice, you will advise a vaccine for someone and not advise a vaccine for somebody else. And that's a judgment I'm sure all of us will have. I'm sure that we are looking for Partha's comments on few specific things that I don't know the answer, and in general. Thank you very much for your patience.